This episode of Fertile Talks is sponsored by ilmeds.co, an international mail order pharmacy specializing in fertility medications. If you're looking to save significantly on your fertility treatments without compromising on quality, ilmeds.co is an excellent choice, offering up to 80% of retail prices. And as a special offer to our listeners, use the code FT24 at checkout to receive a $50 discount on your order. For your convenience, you can find a link to their website in the episode show notes. Thank you, and let's get started. Welcome to Fertile Talks, the global podcast celebrating the diversity of fertility journeys. I'm your host, Dr. Yemi Famuyiwa. Whether you're just starting or simply curious, this is your safe space. In each episode, we will bring you expert insights, heartfelt personal stories, and the latest in reproductive health. Our goal is to break down barriers, tackle stigma, and provide support and hope. So whether you're in the Americas, Africa, or Asia, Fertile Talks is your companion on the path to parenthood. Thank you for tuning in and welcome to Fertile Talks. Good evening. This is Dr. Famuyiwa, and we're going to be hosting Dr. Gibbs. We're going to be talking about the effect of thyroid disease on fertility. So our host today for Fertile Talks is Dr. Dana Gibbs. She is a board-certified ENT specialist and a thyroid specialist, and she focuses on dealing with complex thyroid and hormonal imbalances. So welcome to Fertile Talks, Dr. Gibbs. Can you tell us a little bit about yourself?
Sure. Thank you for inviting me. This is great fun. So I am, as you mentioned, I'm an ear, nose, and throat specialist, and people are always like, okay, that's weird. What are you doing hormones? But what they don't realize is that thyroid is really a core part of ear, nose, and throat. Although most of us just focus on tumors and taking them out. And that is where I started, but it was pretty strange because, when you're in residency, when you're in your training, and all the patients that you see are scary thyroid cancers or, big scary goiters that are going to squish your windpipe and make it to where you can't breathe or stuff like that. Then you get out in private practice and it's like, oh, I've got this lump in my thyroid and it's about this big, maybe half an inch across. And that was the typical patient instead of the scary scaries. And so,
Right.
so I was still, the endocrinologist would send the patient, I would do the surgery, and the patient would come back for their follow-up and they'd feel worse.
Oh, wow.
And I'd be like, well, did you take the thyroid medicine? And they're like, oh, well, they told me I didn't need any.
Oh.
And, their labs, according to the guidelines, would look fine. But they're like, I've gained 20 pounds, then 30, then 40. I feel tired all the time. My hair's falling out, all this stuff. And I got really quickly to where I was like, you know what? If we can follow your thyroid nodule instead of taking it out immediately, let's do that instead. Because, and I kind of got vindicated later because now even the small thyroid cancers, they don't say to take them out right away. They're like, look, 85% of them don't even get bigger.
So you mentioned a big word. I want you to break it down for our audience.
Sure. Sorry.
You used the word goiter.
Okay.
What is a goiter?
What is a goiter? What is a goiter?
Yes.
Goiter is what, so first of all, your thyroid gland sits in the bottom of your neck, in the front, right under your collarbones. And so if you push your fingers on your Adam's apple and then down and then out to the side, about a half an inch from the back of your collarbones, and then you swallow, you can sometimes feel your thyroid gland. And most people can't feel their thyroid gland. It's very thin, it's very soft. You can't really feel it. But a goiter happens for various reasons when your thyroid gland starts to grow and it starts to enlarge. And they can be huge. I've seen goiters as big as my two fists next to each other.
Wow.
And so huge that they were squashing somebody's windpipe to the point that they could barely breathe.
Wow.
And that's the kind of goiter that's like, oh, really scary, has to come out, because you can't breathe well with that in there. But most goiters start gradually and they start pretty small. But when you go to your regular medical doctor and say you started feeling like, my collar feels a little tight or my neck feels a little funny. And when I lay back, I feel a little tight, like something's there. If they put their fingers on that and you swallow, that lump will move up and down and you can feel it. And if it's a goiter, that means the whole gland is involved.
Wow. So
Whereas,
what causes it? What would
well,
cause
a
it?
couple of different things will cause it. Few different things. The first one and the most common one in the United States is an autoimmune disease called Hashimoto's disease. And an autoimmune disease is when your body decides that part of you shouldn't be there and it attacks it and damages it.
Wow.
And in Hashimoto's disease, the attack is by your immune system, by the cells of your immune system, and they go in there and they secrete a whole bunch of lymphocytes. So the lymphocytes, which are part of your blood cells, get in there and damage the tissue and cause swelling and cause lumps, and it gets bigger. And it can get bigger in a very lumpy way that's called a multinodular goiter.
So it's
But
like caused by the body's immune system turning on its own cells, except in this case, the thyroid.
against your thyroid gland, yes,
Yeah.
exactly. And that's not uncommon at all. As a matter of fact, there's a blood test for it called a thyroid peroxidase antibody test
Right.
that you can get done. And if you just randomly do that on everybody in the United States, about 15% of us have that test positive.
Oh, wow.
Doesn't mean you have Hashimoto's disease. It just means that at some point in your life, you have developed that tendency toward those antibodies.
So what would be the first symptoms that someone would notice?
Wow. Most people don't notice anything at all.
Oh, interesting.
Which is really frightening because it's like, oh, I could have an autoimmune disease and not even know it. I mean, I've heard of kids as young as 11 having this. The earliest one I have diagnosed, keeping in mind that I see mostly adults, the earliest one that I've diagnosed was on a girl who was 16.
Oh, wow.
And she came to me because she had a hoarse voice. Wow. And as ENT, that's a common thing we see in ENT. She had a hoarse voice. I looked in there. Her vocal cords looked a little bit swollen. I touched her neck and it felt a little bit funny. Not anything big. But I said, I put 2 and 2 again. Neck feels a little funny. She's hoarse. I better check those antibodies. And sure enough, they were positive. But the other symptom of Hashimoto's besides, your neck can get sore during the early phases of that, would be that you start having either too much thyroid hormone or not enough thyroid hormone in your system, and that can cause symptoms.
So how would someone treat it? What would you need?
Wow. Well, it kind of depends on a lot of stuff, but the first thing that most doctors are going to look at is, are your thyroid hormone levels enough? Are they sufficient? The second thing that I look at, because I see a lot of people who technically have enough thyroid hormone, but they still don't feel good. And I will check the balance of those thyroid hormones to see if you might be overproducing one versus another, as far as that goes. But
So which hormones you mentioned producing one versus the other? Which
versus
ones?
the other. Well, so we're getting deep into we're getting hip deep already here. But anyway, so when your thyroid makes thyroid hormone, it makes two different chemicals. It makes something called T4, which has 4 iodine molecules on it, and it makes something else called T3. And T4 is kind of like the storage hormone. It goes around in your body, bound to other proteins in your blood system, and it kind of waits till it's needed. And then it goes into the cells and gets turned into T3, which is the active hormone. T3 is what goes into the cells and interacts with your DNA and causes you to burn energy and make proteins and do all the activities of thyroid hormone, like growing your hair, like giving you energy, like helping you be warm enough. That's a big one. Making it to where you can actually use your energy to build muscles instead of just put it on as fat, for example.
Yeah, yeah.
In the fertility world, thyroid hormone is super, super important because you just about can't carry a baby to term if you don't have the right hormones and the right balance of hormones. And they can change during the course of the pregnancy a lot. They can change a huge amount. And so
most people are, I guess they've heard that, oh my gosh, you got to be checking your thyroid. You may need to supplement it, blah, blah, blah. So a lot of people do come in and, they want to check. And there's some literature in the popular literature where people think they need to be taking high doses of thyroid. What would you say for that?
high doses of thyroid. I'm very big proponent of checking labs in thyroid. And there are a lot of non-physician thyroid gurus, so to speak, out there that say, oh, high is better and you should take more and you should take natural thyroid and all these things. And truthfully, I tend to, particularly if somebody is contemplating pregnancy or has managed to get pregnant, I'm really all about that balance, because in a normal human, they have a third thyroid hormone called reverse T3. And reverse T3 has specific actions in the fetal tissue that are really, really important. And it's present in normal, healthy people in about a 10-to-1 ratio with the T3.
Okay.
And so I look at that ratio all the time and I check it very carefully and try to keep it right about that 10-to-1 ratio, because you don't want it to be too high and you don't want it to be too low, because if you don't have enough reverse T3, then you don't get the growth of the fetal tissue that you need. And if you have too much reverse T3, then you don't get the maturation of the fetal tissue. So that balance really needs to be there.
Yeah, it's really crucial for getting pregnant and maintaining pregnancy then.
Yes.
Awesome.
Yes.
Awesome.
Yeah. What I have seen happen a lot is that people who have Hashimoto's disease, one of the biggest things that happens to them is that they gradually lose the ability to make enough thyroid hormone.
It's a gradual thing.
It's a gradual process. It can happen over years and years. And so slowly that a person might not even notice that their energy isn't as good as it used to be, that their weight is creeping up, or
so they go from like making too much thyroid hormones and then sort of burn out to not making enough.
Yes.
Okay.
Yes, awesome. Exactly.
So then their medication needs might even change throughout the
over
course
time.
of the
Definitely, they will
yes.
change over time. One of the particular things that happens with Hashimoto's disease is because the hormone levels are fluctuating with that autoimmune attack that they have, that your body has a particular reaction that it does when your thyroid hormone is too high. And that reaction is that it activates an enzyme called deiodinase type 3 that makes a lot of this reverse T3 that I was talking about. And it does that because it's much more dangerous to our bodies to have too high of thyroid as it is to have not enough thyroid. I mean, high thyroid will kill you quick. Thyroid
Versus
storm.
not having enough.
Yeah, versus not having enough, where you can go months and months not having enough thyroid and still be okay. You may not feel good, but you're not going to die from it for quite some time. So your body has this very strong defense against too much thyroid hormone.
Okay.
And so if somebody is on levothyroxine, which is the T4, and they aren't taking any of the T3, then they may have a situation where as they take their pill in the morning, their level goes way up. And the studies have shown that the level of that hormone in your blood peaks at about 3 hours, and then it stays high for about 9 hours, and then it goes back down. But a lot of endocrinologists check your hormone levels at the very, very tail end of that process, right before you go to take the next pill. And so it can tell if you don't have enough, but it misses that too high level. And what happens when you have that high level is that then you don't have enough of the other one, the T3, the active hormone. And so people who don't have enough T3 have a really, really hard time maintaining a pregnancy. And I've seen people, there's an example that I use when I talk to other doctors of a woman who had 4 miscarriages in 2 years. And practically the minute we got her T3 balanced correctly, she became pregnant again. I mean, within 4 weeks of starting the treatment.
So definitely, and it's one of the reasons why when we work up women who are trying to get pregnant, one of the things we do is do a thyroid panel as one of the basic background.
Yes.
So then when we run into trouble is when we would call someone like you and say, hey, listen, this lady's thyroid glands are so out of control.
Out of control.
Can you get it into control?
Can I get it? Yes. Yeah. And what I have seen, so this woman that I use as my example patient, her thyroid hormone labs looked normal. Her T4 looked normal and her TSH looked normal. And those are the normal labs that everybody tests.
Check. Yes.
Yes. And they looked completely fine. But yet she had miscarriage after miscarriage and was losing them very early.
So you would definitely
6
recommend
weeks, 8 weeks.
Yeah, you would definitely adding. I mean, people do check TSH and T4, but I tend to get a full thyroid panel as opposed to just those two, because you could miss something.
Yeah. So what I recommend that people do, in addition to also, so the TSH and the free T4, and then also free T3, and then 2 more labs, which is the total and the reverse T3. And then you just do long division where you put the T3 number on top and the reverse T3 on the bottom, and you get a ratio. You get the T3, the reverse T3, and that ratio needs to be about 10. And if it is, then you're good. And if it is, this poor lady, hers was 2.5.
Oh.
Her reverse T3 was so high that she basically did not have, I mean, and all her other numbers looked normal, but she did not have adequate activation of thyroid to maintain a pregnancy.
Yes.
Because her reverse T3 was so high. And all we had to do to change that with her was take away a little bit of her levothyroxine and add a little bit of the T3 hormone prescription, which is liothyronine, and take the medicine more than once a day so that you don't get these big ups and downs through the day. To take both of them, not just the liothyronine, but also the levothyroxine, and take them more than once a day. And that worked for her. And boom,
Awesome.
she was pregnant. She maintained that pregnancy. She delivered at full term and then turned around and got pregnant and had another baby. And so
This,
it was a really amazing success story for her. And really I use her as a teaching case just because it was so demonstrative of what I tell people over and over again, which is
wow,
that
that's really
looking at
fascinating. Excellent.
that ratio is so important.
Thank you so much that you shed that light. And I think not just for patients, but also for any of our colleagues or nurse practitioners or PAs who are listening, saying
Yeah,
that we
absolutely.
need to be looking beyond just the regular TSH and T4. We need to be doing
Mm-hmm.
the full thyroid panel to
Yes.
be better take care of our patients.
Yeah. And that's not necessary for everybody. I mean, most people with hypothyroidism get their medicine and they feel fine. They feel good. Um, and don't need to be that fussy with it.
Mhm.
But some people, and it's probably on the order of 15% of people, take their levothyroxine and it doesn't make them feel better. And if it does, then they may have Hashimoto's disease. They may have a genetic defect that keeps them from making enough active T3. There are a lot of reasons. And the ones that I see the most common are actually people who are just super stressed out.
Interesting. So that's another, and I know I did talk about stress and fertility in the past. And most people, when they
Mm-hmm.
think of stress, they think of the cortisol axis, but
Yes,
stress can also affect the thyroid axis. So you're looking
absolutely.
at two-pronged ways where stress
Right.
can attack the thyroid,
Well, I mean, it's not two different mechanisms, it's the
yeah,
same
same,
mechanism.
huh?
And this is another point that I make all the time. It's like our bodies cannot tell the difference between a tiger is, living next door or my boss is mean to me. I
Mm,
mean, that your body has one way of responding to that, and that's to release a whole lot of cortisol.
right.
And cortisol does terrible things to your thyroid gland when it's too high all the time. And so yeah, it does a lot of bad things.
Excellent. Excellent. Well, this has been really, really fascinating topic for me. So thank you so much. Now, Dr. Gibbs, if someone wants to get a hold of you and wants to know a deep dive into their thyroid, where can they get a hold of you?
Sure. So my website is www.danagibbsmd.com.
Mhm.
You can find my phone number, my contact information there. I also have a podcast. The podcast is called Beyond the Thyroid,
Awesome.
and you can find that wherever podcasts are available. And I post some of those on a YouTube channel, which is just my name, Dana Gibbs MD. Um, and yeah, that's it.
Awesome. Awesome, Dr. Gibbs. Thank you so much. This has been
You
great.
are
Yes.
very welcome.
All
I
right.
love helping people out with their
Awesome.
thyroid abnormalities, and I really do feel like, in particular, fertility specialists need to hear this message because
Yeah.
it's sometimes it can just be a shockingly
Yeah.
easy transition to, oh, I'm not infertile anymore. Oh
Yeah.
my gosh, you know.
Awesome.
So I see that a lot. And thank you very much for
Thank
having
you
me on.
so
This has
much.
been so
So for
much fun.
our listening audience, if you've liked what you've heard, you can reach out to Dr. Gibbs. You can like, follow us, subscribe to our channel, and thank you so much. This has been great. Thank you for tuning in to Fertile Talks. We hope today's episode has provided you with valuable insights and support for your fertility journey. Remember, you are not alone. Now, if you have any questions or topics you'd like us to cover, please simply leave us a comment. And please don't forget to like, share, and subscribe with a friend. Your ratings, your shares, and your reviews are greatly appreciated and is going to help us serve more of our listening audience. Thank you once again. This is Dr. Famuyiwa.